Welcome to the Funnel Effect.
Today, we're diving into something pretty significant in cardiovascular medicine. It's the brand new 2025 Acacasep-Names-Skisky Guideline for the management of patients with acute coronary syndromes.
Yeah, and that's quite a mouthful of acronyms, but it basically means all the key players, cardiology, emergency medicine, EMS, interventional cardiology, they've all come together. This huge guideline was led by Rao et al., but also includes key collaborators like Amy W. Talbot, Pam R. Taub, Marlene S. Williams, and many others.
It's a massive consensus document, and our goal today really is to give you the essential takeaways from this deep dive. We want to unpack the critical updates, maybe some shifts in strategy, and definitely highlight some surprising data points. This covers the whole spectrum of acute coronary syndromes, or ACS, so STEMI, NST, ECS, and unstable angina.
And getting this right is just incredibly important. I mean, the numbers are staggering. You're looking at around 805,000 heart attacks, AMIs, every year in the U.S.
Huge numbers.
And the economic cost, something like $84.9 billion. So when the stakes are that high, every single change in these guidelines is backed by some serious evidence.
Exactly. So maybe let's start with the basics. Define ACS, and then jump right into why time is just absolutely critical according to these new guidelines.
Okay, so when we say acute coronary syndrome, what's the actual mechanism, the core injury we're focused on here?
Well, at its heart, ACS is usually about atherosclerotic plaque disruption. So you have this fatty deposit plaque in the coronary artery wall,
Right.
and it either ruptures or maybe it erodes. That kicks off the body's clotting system, you get thrombosis, a clot forms.
And that blocks the blood flow.
Partially or completely, yeah. And that sudden lack of blood to the heart muscle, that's myocardial ischemia.
Okay, and the different types of ACS, like STEMI and NSTEMI, that just depends on how bad the blockage is.
Pretty much. We classify them based on the ECG findings and whether there's actual heart muscle damage, which we measure with biomarkers like troponin.
So walk us through the three main ones.
Sure. First, you've got unstable angina, or UA. Here, there's ischemia, maybe severe, maybe transient, but crucially, it doesn't cause enough damage to raise those cardiac biomarkers. No troponin elevation.
Got it. No damage marker.
Then there's NSTEMI non-ST segment elevation MI. Here, the blockage is usually partial. It causes what we call subendocardial ischemia, but it does cause enough damage to elevate troponin.
So biomarkers are up, but the ECG pattern is different.
Right. And finally, STEMI ST segment elevation MI. This is typically the most severe, often a complete sudden blockage causing damage through the full thickness of the heart wall, a transmural infarction. That's what gives you the characteristic ST elevation on the ECG.
And the guideline specifically focuses on one type of MI more than others, doesn't it?
Yes, that's a key point. This guideline is overwhelmingly focused on type 1 MI. That's the classic heart attack caused by that plaque rupture or erosion. The acute coronary atherothrombosis we just talked about. They make sure to distinguish it from type 2 MI, which is different. That's caused by a supply-demand mismatch. Think severe anemia, really fast heart rate, low oxygen levels. The underlying coronaries might be okay, but the heart isn't getting enough oxygen for other reasons.
And it's also distinct from things like MINOCA.
Exactly. MINOCA, myocardial infarction with non-obstructive coronary arteries, is another separate category. The focus here is type 1 MI because that's where these really time-sensitive, invasive treatments are most critical.
Okay, let's talk about time, because this seems to be where the guidelines are really pushing for a faster standard of care, starting even before the hospital. How important is calling EMS versus driving yourself?
Oh, it's strongly recommended to use emergency medical services, EMS. Absolutely. It's not just about getting there faster, although that's part of it. It's really about safety.
FD Tau.
Well, in those first few hours of ACS, the risk of life-threatening heart rhythms like ventricular fibrillation or even sudden cardiac arrest is incredibly high. EMS crews can monitor the patient, they can defibrillate if needed, they can start treatments right there in the ambulance. A private car just can't offer that level of immediate care and monitoring. It's genuinely a lifeline.
And the big-time target driving everything seems to be this golden 10 minutes. What exactly needs to happen in that window?
It's a huge challenge, but yeah, it's non-negotiable according to the guidelines. A 12-lead ECG has to be acquired and interpreted within 10 minutes of first medical contact FMC.
10 minutes. That's incredibly fast.
It is, but that 12-lead ECG is the quickest, most definitive tool we have to spot a STEMI, which needs immediate reperfusion therapy to save heart muscle. Hitting that 10-minute target is basically a benchmark for a well-functioning emergency system.
Okay, that makes sense if the first ECG clearly shows a STEMI. But I think interesting, they recommend doing serial ECGs if the first one isn't diagnostic. Doesn't that add time back in?
It might seem counterintuitive, but it's crucial. The situation in the coronary artery is dynamic, it's changing. The clot might not be fully blocking the artery right when that first ECG is done.
Ah, okay.
It can get worse quickly, and the data backs this up. Doing a second or even a third ECG during transport can pick up something like 15% of additional STEMI cases that were missed on the first go. So if you still suspect ACS clinically, you can't just rely on one negative early ECG.
Got it. So keep checking. And this rapid identification is also helped by the newer blood tests, right? The high-sensitivity troponins.
Absolutely. High-sensitivity cardiac troponin assays, HSCTN, have been a real game changer. They dramatically shorten the time needed to either diagnose an MI or safely rule it out.
Yeah, much shorter.
Well, with the older conventional troponin tests, you needed to repeat the blood draw maybe 3 to 6 hours later.
Right, that took a while.
Now, with high-sensitivity troponin, the guidelines recommend repeat sampling intervals of just 1 to 2 hours. Being able to make a confident decision that quickly within basically 2 hours has massively streamlined how we handle NSTE ACS patients in the emergency department.
And all this speed, this urgency, it all points to what you call the mortality clock. Once a STEMI is confirmed, what's the time goal for treatment, and what's the penalty for missing it?
The main goal is for primary percutaneous coronary intervention, or PPCI basically, getting the artery open with a balloon or stent. The target time is from first medical contact to the device being activated in the cath lab.
And that time is?
It needs to be 90 minutes or less if the patient arrives directly at a hospital that can do PCI. If the patient needs to be transferred from another hospital, the target is 120 minutes or less.
90 or 120 minutes.
Yeah.
And the consequence if you're delayed?
It's stark. The evidence is really clear on this. For every 30-minute delay in getting that artery open with PPCI, the relative risk of dying within 1 year increases by about 7.5%.
Wow. 7.5% higher risk of death for every half-hour delay.
Yes. It's a direct, pretty linear relationship. Time really is muscle, and time lost is life lost.
That statistic, 7.5% per 30 minutes, it feels like it changes everything. It's not just about doctors working faster. It implies huge system changes are needed, right?
Absolutely. It mandates things like having protocols where EMS can activate the cath lab directly from the field, bypassing the emergency department entirely for confirmed STEMIs.
Streamlining the whole process.
Exactly. You need cooperation between different hospitals for smooth transfers. You need buy-in from administrators. Consistently hitting a 90 or 120-minute target requires near-perfect coordination between EMS, the ED, the cath lab team. Every minute literally counts. Hashtag tag 1.3 managing cardiac arrest survivors.
Okay, let's talk about a really tough group. Patients who survive a sudden cardiac arrest. If they have a STEMI on their ECG after they get a pulse back, what's the plan?
Right, after return of spontaneous circulation, or ROSC.
Huh.
If a patient resuscitated from cardiac arrest does show a STEMI on the ECG, they need to be transferred immediately and preferentially to a hospital that can do PPCI.
And if they wake up?
If they're awake and responsive after ROSC and they get timely revascularization, their chances of survival are actually pretty similar to STEMI patients who never arrested in the first place, so urgency is key.
But what about the patients who don't wake up, who remain comatose, and don't have a clear STEMI on their ECG? The guidelines seem hesitant about rushing them to the cath lab. Why is that? It feels like you'd want to look for a blockage.
This is a really important change driven by recent trials. For that specific group stable, comatose patient, no STEMI on ECG immediate angiography is now not recommended. The procedure is typically deferred.
Deferred. Why? What did those trials show?
Well, there were about 6 major randomized trials looking at this exact question, and consistently they found no significant benefit in terms of overall survival or good neurological recovery when they compared rushing those patients to the cath lab immediately versus a strategy of delaying angiography or only doing it selectively later on.
So immediate blockage hunting didn't help outcomes in that group.
Correct. In that stable, non-STEMI post-arrest patient, the focus shifts. It becomes more about aggressive neurological assessment, supportive care, often including targeted temperature management to protect the brain, rather than an immediate invasive procedure.
Okay, so when you're evaluating these comatose patients, are there signs that suggest a poor neurological outcome? Things that might make aggressive intervention less beneficial?
Yes, the guidelines list several unfavorable prognostic features. These are signs that suggest a severe brain injury due to lack of oxygen.
Like what?
Things like if the arrest wasn't witnessed, if the initial heart rhythm was non-shockable like a systole or PEA, if CPR went on for a very long time, say over 30 minutes. Also, very high lactate levels, often above 7 millimole, being older, maybe over 85, or having severe kidney failure requiring dialysis.
So if those factors are present.
If several of those are present, the likelihood of a good neurological recovery drops quite a bit. And the decision about whether to proceed with complex invasive procedures becomes much more nuanced and needs to be carefully individualized.
That really highlights the need for precision and system coordination. Okay, let's shift from these urgent procedures to the medications, the standard medical therapies that start right away.
Yeah, this is another area with significant updates. We're seeing a clear trend towards using more potent drugs, both for antiplatelet therapy and lipid lowering, but also a much sharper focus on managing the risks, especially bleeding.
Aspirin is still the cornerstone, right? But there's specific guidance now on the dose, particularly long-term.
Correct. Everyone gets a loading dose of aspirin right away, usually 162 to 325 milligrams, often chewable for faster absorption. But for long-term daily maintenance therapy, the guidelines strongly recommend a low dose, specifically 75 to 100 milligrams daily.
Why the switch to low dose for maintenance? Didn't people used to take the higher 325 milligram dose long-term?
They did, but the evidence showed that the higher maintenance dose, like 300 or 325 milligrams, wasn't actually any better than the low dose at preventing future heart attacks or strokes, what we call MEC, major adverse cardiovascular events.
Okay, no extra benefit.
Right. But the higher dose did significantly increase the risk of bleeding, both minor and major, especially gastrointestinal bleeding. So the low dose gives you the same protective effect with less bleeding risk. It's a better trade-off long-term. #tag 2.1 antiplatelet strategies, DPT. So beyond aspirin, we add a second antiplatelet agent, a P2Y12 inhibitor. This is dual antiplatelet therapy, or DAPT. And for patients with NSTE, ACS who are going for PCI, the guidelines now clearly favor the more potent agents.
Which are?
Prasugrel or ticagrelor. They're generally recommended over the older drug, clopidogrel, because they provide stronger platelet inhibition and better reduction in MACE and stent thrombosis.
More potent usually means more effective, but also potentially more risky, right?
Yeah.
What are the big trade-offs with prasugrel and ticagrelor?
The main trade-off is bleeding risk. Both ticagrelor and prasugrel do carry a higher risk of bleeding compared to clopidogrel. That's something you always have to weigh.
And is there anyone who absolutely shouldn't get prasugrel?
Yes, there's a critical contraindication. Prasugrel should never be given to a patient with a prior history of stroke or TIA, a transient ischemic attack.
Why is that restriction so absolute?
Because the clinical trials showed that in patients with a history of stroke or TIA, the increased potency of prasugrel led to significantly worse net outcomes. Any benefit from preventing heart attacks was completely wiped out or even overshadowed by a much higher risk of causing dangerous bleeding, especially bleeding in the brain.
That's a crucial safety point.
Absolutely vital. So clopidogrel, while maybe less potent, is still a very important and effective option, particularly for patients who are at high risk of bleeding or who have that specific contraindication to prasugrel.
Now, there was an interesting point about drug interactions in the acute setting. Common pain medications might interfere with these P2Y12 drugs.
Yes, that's right. We're talking about opioid pain relievers like morphine or fentanyl, which are often used for severe chest pain. The issue is that opioids can slow down how quickly the stomach empties and reduce movement in the intestines. This can delay the absorption of oral P2Y12 inhibitors like ticagrelor or clopidogrel, meaning it takes longer for them to start working.
And in an acute heart attack, you want those drugs working fast.
Exactly. So clinicians need to be aware of this potential interaction and maybe consider alternative pain relief strategies, or in some very urgent cases, using an intravenous antiplatelet agent that bypasses the gut altogether.
Good point. And let's quickly touch on two other common things: oxygen and NSAIDs. What's the guidance there now?
For oxygen, the recommendation is much more restrictive now. Supplemental oxygen should only be given if the patient's oxygen saturation level is actually measured and found to be below 90%.
So no more routine oxygen for everyone with chest pain.
No, routine use in patients with saturation 90% or higher is specifically not recommended. Studies haven't shown it helps cardiovascular outcomes, and there's even some concern it could cause coronary arteries to constrict, which is the opposite of what you want.
Right. Okay. And what about NSAIDs like ibuprofen?
Non-aspirin NSAIDs should definitely be avoided during the acute phase of ACS. There's strong evidence linking their use around the time of a heart attack to an increased risk of MP, including reinfarction, heart failure, and even death. Hashtag tech tag 2.2 aggressive lipid management.
Okay, shifting from anti-clotting to cholesterol. The guidelines seem incredibly aggressive now about lowering LDL cholesterol. It feels like a real change in philosophy.
It really is a profound shift. The message is clear. High-intensity statin therapy should be started for all patients with ACS right away. And importantly, there's an option to start ezetimibe at the same time.
So potentially 2 lipid drugs right from the beginning.
Yes, the idea is maximum intensity up front. We're not waiting to see if the statin alone is enough.
And what's the LDL target now? When do you add other non-statin drugs?
The threshold is pretty low.
Yeah.
If a patient is on the highest dose of statin they can tolerate and their LDL cholesterol is still 70 milli-GDL or higher, that's 1.8 millibol, then adding a non-statin agent is recommended.
And those agents are?
That's where drugs like ezetimibe come in, or the PCSK9 inhibitors, maybe inclisiran or bempedoic acid.
I think the guidelines suggest pushing even lower than 70.
That's the core of the philosophical shift. The guidelines really embrace the lower is better concept now for LDL. There's continuous evidence showing that reducing LDL well below 70, even down below 50 milli-GDL, keeps reducing the risk of ME.
So for these very high-risk patients post-ACS.
Exactly. For those highest risk patients, the guideline says it's reasonable to intensify therapy even if their LDL is already between 55 and just under 70 milli-GDL while on a max tolerated statin. We're moving away from just hitting a target number and towards achieving the maximum possible LDL reduction safely.
Can you quickly remind us what these different non-statin drugs do? Let's start with ezetimibe.
Sure. Ezetimibe works in the gut. It blocks a protein called NPC1L1, which stops cholesterol from being absorbed from your diet and bile. It usually gives you about a 15–25% extra reduction in LDL when added to a statin. And we know it works. The IMPROVE-IT trial showed it reduced MACE after ACS. Plus, it's generally well-tolerated and available as a generic, often the first drug added.
Okay, then the really powerful ones, the PCSK9 inhibitors.
Right, PCSK9 inhibitors like evolocumab or alirocumab. These are injectable monoclonal antibodies. They work by stopping the PCSK9 protein from destroying LDL receptors on the liver surface.
Meaning more receptors stay active.
Exactly. More receptors mean the liver can pull much more LDL cholesterol out of the blood. These drugs can lower LDL by a massive amount, often around 60%. The big trials like Fourier suggested they might be even more beneficial when started relatively soon after the ACS event. And there's even data showing they can help regress or shrink coronary plaque.
Impressive. And the last one, bempedoic acid. Who is that for?
Bempedoic acid is an oral drug. It works by inhibiting an enzyme called ATP citrate lyase, which is involved in cholesterol production. It gives about a 20% LDL reduction. Its main niche is really for patients who truly cannot tolerate statins due to muscle side effects.
Proven in trials.
Yes. The CLEAR Outcomes trial showed it reduced MACE by about 13% in that specific statin-intolerant population. But you do need to watch for potential side effects, like a possible increase in gout or gallstones.
So the big picture for lipids is hit hard, hit early, use multiple drugs if needed to get that LDL way down, because that window right after ACS is critical for changing long-term risk.
That sums it up perfectly.
Okay, let's move into the cath lab now. We're talking about the invasive procedures to actually open the blocked artery. And there have been some really definitive changes here regarding how it's done, right?
Yes, absolutely. Based on strong evidence, there are clear shifts in best practices for the procedure itself.
The first big one seems to be about where you access the artery. Radial access going through the wrist is now strongly preferred over femoral access in the groin. Why such a strong preference?
It sounds like a technical detail, but the data is just overwhelming. Using radial access for PCI is independently linked to a really striking 51% relative risk reduction in major bleeding compared to femoral access.
51% less major bleeding. That's huge.
It is. And perhaps even more importantly, it's also associated with a 24% relative reduction in all-cause death.
Wow. How does just changing the access site lead to fewer deaths?
It's mostly driven by that reduction in bleeding. Femoral access site bleeding can be severe, sometimes leading to large hematomas, retroperitoneal bleeding, and often requiring blood transfusions.
And transfusions after a heart attack are bad.
Yes, needing a transfusion in the context of an MI is strongly associated with worse outcomes, including higher mortality. Radial access sites are much easier to compress and monitor. Bleeding is less common and usually less severe. So by dramatically reducing major bleeding and transfusions, radial access improves survival. It's really become a major patient safety standard.
Okay, that makes sense. Now, the second big procedural change is about a technique that used to be common. Aspiration thrombectomy, sucking the clot out before stenting. Why is that not routine anymore?
Yeah, that's another area where intuition didn't quite match the data. Routine use of manual aspiration thrombectomy right before putting the stent in is now firmly not recommended.
Why not? Seems like getting the clot out first would be good.
Several large randomized trials looked at this, and they simply failed to show any consistent clinical benefit in terms of preventing death, reinfarction, or stroke. In fact, there were some signals, particularly in one large trial, suggesting a potential small increase in stroke risk with routine thrombectomy compared to just doing standard PCI.
So, no benefit and maybe a small risk.
Exactly. So now it's reserved only as a bailout procedure. If there's a massive amount of clot that's preventing blood flow, even after initial attempts, what we call no reflow, then maybe you'd consider using it selectively, but not routinely up front.
Let's switch gears slightly to NSTE-ACS. These patients aren't usually as immediately critical as STEMI patients, so deciding when to do the angiography and potential PCI requires more nuance, right? It depends on their risk.
That's exactly right. Risk stratification is key for NST-ECS. While tools like the TMI or GRACE risk scores exist, the guidelines emphasize that the decision on timing is often driven more by the patient's immediate clinical stability and specific high-risk features.
So they break it down into different time frames. Who needs to go to the cath lab immediately?
That's the immediate invasive strategy, meaning angiography within less than 2 hours. This is reserved for the most unstable patients. We're talking about people with chest pain that won't go away despite all the medications, signs of shock or hemodynamic instability like very low blood pressure, or dangerous electrical instability like recurrent ventricular tachycardia or fibrillation.
Those patients are actively crashing.
Essentially, yes, they need intervention right away.
Okay, what about patients who are high risk based on their tests or history, but are stable right now?
They fall into the early invasive strategy. For these patients, angiography within 24 hours is considered reasonable. This includes patients with significantly elevated troponin levels, maybe signs of new or worsening heart failure, or ongoing significant ECG changes suggesting ischemia.
Does going early within 24 hours improve survival for them?
The evidence is a bit mixed for all NST-ACS patients, but in subgroup analyses of higher-risk patients, an early invasive strategy does seem to reduce the rate of MAKE-CE compared to waiting longer. So, for the high-risk but currently stable group, within 24 hours is the preferred approach.
And then there are the lower-risk NSTE-ACS patients.
Right. For patients deemed intermediate or low risk, a delayed or selective invasive strategy is appropriate. This means angiography can be pushed back, maybe to 48 or even 72 hours after they present.
Or maybe not done at all.
Or potentially not done invasively at all. For the truly low-risk patients, you might do non-invasive testing first, like a stress test or maybe a CT coronary angiogram. If those tests don't show significant ischemia, you might manage them medically without needing an invasive angiogram. It's about using resources wisely and avoiding unnecessary procedures in lower-risk individuals. Hashtag CHAG 3.3, the complication of multivessel disease, MVD.
A common scenario is finding blockages not just in the artery causing the heart attack, but in other coronary arteries too, multivessel disease, or MVD. How does that complicate the treatment plan?
MVD definitely adds complexity, especially in the acute setting. When you have a STEMI patient, you obviously have to open the culprit artery immediately. The question then becomes, what about the other significant blockages? Do you fix them now or wait?
What do the guidelines suggest for a stable STEMI patient with MVD?
If the patient is stable after the culprit vessel is opened, and the other blockages, the MVD, are considered low complexity, meaning they're relatively straightforward lesions, not in the left main artery, etc., then doing multivessel PCI right then and there during the same procedure may be preferred over bringing the patient back for a separate staged procedure later.
Why fix everything at once?
Several trials have shown that completing the revascularization upfront in these selected patients reduces the risk of future cardiovascular events, like needing another PCI or having another heart attack, compared to just fixing the culprit and staging the rest.
But that changes if the disease is more complex.
Absolutely. If the patient has very complex MVD, especially if it involves the left main coronary artery, or if they have complex blockages and diabetes, then coronary artery bypass grafting surgery, CABG, often provides better long-term outcomes, particularly regarding survival and the need for repeat procedures compared to trying to fix everything with stents, PCI. That requires a heart team discussion. Hashtag tagged 3.4, managing cardiogenic shock, the culprit-only rule.
Now, for arguably the highest risk situation, ACS complicated by cardiogenic shock, mortality is incredibly high here. What's the absolute priority?
The number one priority is immediate revascularization of the culprit vessel, the artery that caused the heart attack and led to the shock. Getting that vessel open, usually with PCI but sometimes CIBG, is critical for survival.
Okay, open the culprit artery ASAP, but there's a really important warning in the guidelines about not fixing other blocked arteries at the same time in shock patients, right?
Yes, this is a major practice-changing recommendation based largely on the culprit shock trial. Routine PCI of a non-infarct-related artery, meaning a blockage in a vessel other than the one causing the shock at the time of the initial procedure, is strongly not recommended in patients with cardiogenic shock.
That seems counterintuitive again. If someone is in shock because their heart isn't pumping well due to blocked arteries, wouldn't you want to open all the significant blockages right away?
You'd think so, but the culprit shock trial showed the opposite. Patients in shock are incredibly fragile. Performing multi-vessel PCI in that setting, which means a longer procedure, more contrast dye, more stress on the patient, was actually associated with a significantly higher risk of death or needing dialysis for kidney failure compared to just fixing the culprit vessel quickly and getting out.
So less is more in this situation.
In the acute shock phase, yes. The strategy is to stabilize the patient by opening the culprit lesion only, support their hemodynamics, and then, if they survive and stabilize, consider addressing the other blockages in a staged manner later on. It's about prioritizing immediate survival.
What about devices to help the heart pump? Mechanical circulatory support or MCS? Do things like balloon pumps help in shock?
The guidelines are pretty cautious here. Routine use of the intra-aortic balloon pump, IABP, is generally not recommended based on trial data showing no consistent survival benefit. Similarly, VA ECMO, a more aggressive form of support, isn't recommended routinely due to lack of proven benefit and potential complications.
Are there any devices that might be considered?
There's one exception mentioned, a microaxial intravascular flow pump, like Impella. The guidelines say this may be reasonable in very selected patients with particularly severe or refractory cardiogenic shock where other measures are failing.
But with caveats.
Yes, definitely with caveats. While it can provide more powerful hemodynamic support, its use is often associated with increased complications, especially vascular issues like bleeding or limb ischemia related to the large catheter size. Careful insertion technique, often using ultrasound guidance, is crucial to minimize these risks.
Okay, so the patient has made it through the acute phase, the artery is opened, they're stabilized. Now the focus shifts completely to the long-haul secondary prevention and reducing the risk of this happening again.
Yeah.
A big part of that is managing DPT long-term, right?
Absolutely. That balance between preventing clots and avoiding bleeding continues long after discharge. Hashtag 4.1 DPT and bleeding risk post-discharge. Because the risk of clotting remains elevated for quite some time after ACS, the standard recommendation is still to continue DPT, that's aspirin plus a P2Y12 inhibitor for at least 1 full year in patients who don't have a particularly high risk of bleeding.
But many patients do have a high bleeding risk. What's the strategy for them now?
Yeah.
It seems to be an area where new trial data has really changed things.
Yes, trials like MASTER-DAPT have given us better options. For patients identified as having a high bleeding risk, we now have evidence-based strategies to shorten the duration of DPT to reduce that risk.
You sure?
One strategy is if a patient has tolerated DPT, say with ticagrelor, for a shorter period, maybe just 1 month after their PCI, you can actually stop the aspirin and continue with just ticagrelor monotherapy.
Just one antiplatelet drug after only a month.
In high bleeding risk patients, yes. This approach has been shown to significantly reduce bleeding complications compared to continuing DPT for a full year without a clear signal of increased heart attacks or stent thrombosis. It's a major step forward for managing these complex patients.
How do you systematically define high bleeding risk? What puts someone in that category where you'd consider shorter DPT?
Clinicians generally use standardized criteria like the Academic Research Consortium for High Bleeding Risk or ARC-HBR criteria. These help identify patients who are most vulnerable.
What kind of factors are included?
Key things include being older, usually age 75 or above, needing long-term anticoagulation for another reason, like atrial fibrillation, having severe chronic kidney disease, a history of previous major bleeding, like intracranial or gastrointestinal bleeding, or having very low platelet counts or severe anemia. If a patient meets one or more of these major criteria or several minor ones, then considering an abbreviated DPT strategy becomes really important. Hashtag 4.2, addressing disparities in care. Another really critical section in these new guidelines is the explicit focus on health disparities. The document directly calls out the fact that outcomes and treatment for ACS are not the same across different racial and sex groups.
That's an important conversation to have. What are some of the key racial gaps they highlight?
Well, the data consistently shows, for instance, that the incidence of myocardial infarction is higher among Black men compared to non-Hispanic white men.
Why is that?
It's complex and multifactorial. Part of it relates to a higher prevalence of underlying risk factors like high blood pressure, diabetes, and obesity in some communities. But critically, studies also document disparities in the care received. Black patients, for example, are sometimes less likely to receive guideline-recommended medications after a heart attack or face barriers to adhering to them.
So it's both risk factors and treatment differences.
Yes. And addressing this requires tackling those underlying social determinants of health access to healthy food, safe places to exercise, affordable health care, as well as ensuring equitable delivery of guideline-based medical care.
What about disparities based on sex? How do women experience ACS differently?
This is another major area. Women tend to present with ACS about 10 years later in life than men, on average. This often means they have accumulated more risk factors by the time they have their event.
But the bigger issue is often how they present.
Right, exactly. While chest pain is still common, women are significantly more likely than men to present with what are considered atypical symptoms.
Such as?
Things like shortness of breath, unusual or extreme fatigue, pain in the jaw, neck or back, nausea, indigestion. These symptoms might not immediately scream heart attack in the way classic crushing chest pain does.
And how does that affect their care?
Unfortunately, studies show that this difference in presentation can lead to delays in diagnosis for women. They might be less likely to have their symptoms correctly attributed to ACS quickly, and consequently, they may be less likely to receive timely guideline-directed medical therapy, including things like angiography and revascularization, compared to men presenting with similar severity of disease.
That suggests potential biases in how symptoms are interpreted.
It highlights the need for greater awareness among healthcare providers about the diverse ways ACS can present, especially in women. It also points to potential implicit biases in decision-making.
So tackling these disparities isn't just about better drugs or procedures. It's systemic.
Precisely. The guidelines emphasize that bridging these gaps needs a multi-pronged approach. Better provider education on symptom variability and bias awareness, community programs focused on primary prevention and risk factor control, and importantly, policy changes at a higher level to address those fundamental social determinants of health that create inequities in the first place. Hashtag 4.3 recovery, education, and system gaps.
Okay, let's talk about life after ACS. Cardiac rehabilitation, or CR, is mentioned as crucial. Why is it so important, and why doesn't everyone who needs it get it?
Cardiac rehab is really the cornerstone of secondary prevention after a major cardiac event like ACS. It's a structured program, usually involving monitored exercise, education about heart-healthy living, counseling on stress management, and medication adherence.
But it works.
The evidence is overwhelming. Participating in CR is proven to improve survival, significantly reduce the chances of having another heart attack, and decrease hospital readmissions. It improves quality of life, functional capacity. It's incredibly beneficial.
So why the underutilization?
That's the frustrating part. Despite the clear benefits, referral and participation rates are disappointingly low, particularly among women, older adults, and individuals from underrepresented racial and ethnic groups. The barriers are numerous: cost and insurance coverage issues, transportation difficulties, lack of programs in rural areas, work or family caregiving responsibilities.
Are there alternatives emerging to help with access?
Yes, home-based cardiac rehab programs are gaining traction. These try to deliver the core components of CR remotely, often using technology like telehealth, activity trackers, and phone coaching.
Are they as good as traditional center-based programs?
Early evidence suggests they can achieve similar improvements in risk factors and quality of life, and they definitely improve access. However, the guidelines do note we need a bit more robust long-term data, especially on safety and outcomes for the highest-risk patients managed purely with home-based models. But it's a very promising direction.
And beyond formal rehab, patient education at discharge seems critical. How did the guidelines say this should be done effectively?
Discharge is a key moment. The instructions need to be really clear, patient-centered, and provided in multiple formats, both written and verbal. They need to cover medications, what, why, when, side effects, activity guidelines, dietary advice, recognizing warning signs of trouble, and definitely include that referral to cardiac rehab.
How do you make sure the patient actually understands all that complex information?
The guideline specifically recommends using the teach-back method. This isn't just telling the patient what to do, it's asking them to explain the plan back to you in their own words. Can you tell me how you're going to take this new medication? Or what symptoms should you call us about? It's a simple but powerful way to check comprehension and ensure the patient is truly equipped for self-management.
We've covered a tremendous amount. Before we wrap up, the guidelines themselves pointed out areas where the evidence is still lacking, things they couldn't definitively answer. What are some of the biggest remaining questions or future research needs?
Yeah, Section 12 of the guideline is all about gaps in knowledge. One interesting one is actually quite fundamental. We still don't have a universally agreed upon precise definition of when someone transitions from having an acute coronary syndrome to a chronic coronary syndrome.
Why does that distinction matter?
Well, it has implications for how long certain aggressive therapies like DAPT should continue. It affects prognosis, patient communication, even insurance and disability classifications. Nailing down that transition point is surprisingly tricky but important.
What about some of the newer drug classes that are transforming other areas of cardiology, like the SGLT2 inhibitors or GLP-1 receptor agonists? Are they ready for prime time right after ACS?
That's a huge area of interest. We know these drugs are fantastic for patients with heart failure and manual diabetes, but their role when started immediately after an ACS event, especially in patients who don't already have heart failure or diabetes, is still unclear.
So more research needed there.
Definitely. We need dedicated randomized trials to figure out if starting these powerful drugs early post-ACS provides benefit in a broader population. That's a major potential therapeutic avenue for the future. Another area mentioned is optimizing treatment for blood clots that can form inside the heart's left ventricle after a large MN side. We need better data comparing the newer direct oral anticoagulants, DOACs, to traditional warfarin in that setting. Hashtag outro.
This has been a really comprehensive deep dive into these crucial 2025 ACS guidelines. It's clear how evidence keeps pushing us towards faster, safer, and more personalized care. If we had to summarize the absolute must-know changes for you, the listener, what would they be?
I'd say first, that relentless focus on time for STEMI. Hitting that 90-minute or 120-minute FMC to device goal is paramount, underscored by that sobering 7.5% mortality increase for every 30-minute delay.
Second, the really aggressive lipid-lowering strategy, starting high-intensity stents plus maybe ezetimibe up front, and aiming for LDL levels well below 70, even below 55 in high-risk folks.
Third, the procedural mandates for safety. Radial access being the standard of care due to reduced bleeding and mortality, and the definitive move away from routine aspiration thrombectomy.
And fourth, that critical lesson from culprit shock. In cardiogenic shock, affects only the culprit artery initially. Resisting the urge to do multi-vessel PCI in that unstable setting saves lives and kidneys. It really forces us to trust the trial data over intuition sometimes.
Absolutely. And thinking ahead, given how much relies on speed, that 10-minute ECG, the 90-minute reperfusion, maybe the provocative thought for you is about technology. How soon will artificial intelligence, maybe integrated into EMS systems or smartwatches, be able to reliably interpret ECGs, predict risk, and activate pathways even faster than humans currently can?
Could AI help us consistently meet these incredibly tight time targets?
It's a fascinating possibility. The next iteration of these guidelines might look very different if technology can help bridge that gap between guideline goals and real-world practice. It's definitely something to watch.
A powerful thought indeed, for clinicians, engineers, and patients alike.
Agreed.
Thank you for watching The Funnel Effect.